Good afternoon and welcome to our Neuroscience lecture series. I am Dr. Galit Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health International. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America, the Caribbean, and everyone joining us today. During this interactive presentation, you will have the ability to ask questions via the Q&A feature located in the bottom of your screen. I will be your moderator for today's lecture. This afternoon, I have the distinct pleasure of introducing Dr. Andres Restrepo. His presentation is titled EMG and Nerve Conduction, When to Order It, a tool for pain and spine, physicians and hand surgeons. Dr. Restrepo is a board-certified physician, physical medicine and rehabilitation physician at Baptist Health Miami Neuroscience Institute. Dr. Restrepo specializes in physical medicine and rehabilitation, electrodiagnosis, regenerative medicine, and musculoskeletal conditions, including arthritis. Dr. Restrepo received his medical training at Pontifical Xaverian University Faculty of Medicine in Bogota, Colombia. He completed his physical medicine and rehabilitation residency at St. Vincent's Hospital and Medical Center in New York City. Dr. Restrepo joined Miami Neuroscience Institute from Conviva Physicians Group, where he served as a regional medical director of rehabilitation medicine. He was a principal investigator in research study that demonstrated that exercise prevented falls and increased functional independence in older adults. He also served as an associate professor and director of the Physical Medicine and Rehabilitation Residency program at Jackson Memorial Hospital. Dr. Restrepo has published medical articles and has lectured at different national conferences. He is a member of several professional associations, including the American Medical Association and a diplomat member of the American Academy of Physical Medicine and Rehabilitation. Dr. Restrepo is fluent in English and Spanish. Please let's give a warm welcome to Dr. Andres Restrepo. Dr. Restrepo, what a pleasure having you. Thank you so much for joining us this afternoon.
Thank you very much for that introduction, Dr. Hakim. And I'm gonna share my screen right now.
Please.
So we're gonna talk about a topic that it's a little specialized, but it's very good for all all physicians. The Miami Neuroscience Institute has Physiatrist, and we focus on spine care. So I'm going to talk about EMGs and nerve conduction studies. I'm going to start with an introduction in what an EMG is and where does it come from. When you get a report from a physiatrist or a neurologist that actually also do these tests, how to interpret them, what is the language that we use within the report. And I'm going to note some articles in regards of the importance of ordering these tests to help the physicians with other diagnostics measurements. So I don't have any relevant financial relationships with any companies to disclose. And this presentation will not include discussion of off-label or on a usage of any other one. So upon completion of the presentations, you should be able to describe the physiology of electrodiagnostics, explain when it's best to request an electrodiagnostic consultation, examine how to best interpret test results for a nerve conduction study and electromyography, identify electromyography findings in cervical, thoracic, and lumbar radiculopathies. And we're going to have a little discussion about hand referral for upper extremities for the hand surgeons. So what is EMG stands for? So EMG stands for electromyography, like the EKG for the heart. EMG has two parts. Is the nerve conduction study, that is the electrical part when we shock the patients with electricity, and the needle part, that is the needle EMG that give us the relationship for myopathies, radiculopathies, or chronic neuropathies. So it's commonly used to diagnose, as I said before, entrapment neuropathies such as carpal tunnel syndrome, cubital tunnel syndrome, plexopathies that happen after radiation, radiculopathies, meaning nerve root disorders, neuromuscular junction disorders, myopathies, and anterior horn cell diseases. It can prognosticate functional recovery. It has a role in localization of the site of lesion and identifying the pathology as well. So the typical electrodiagnostic consultation involves a focused neuromuscular history and physical examination. The examination of muscles and nerve utilizing the nerve conduction studies, an EMG, and the determination of a final diagnosis. So according to the American Academy of Neuromuscular and Electrodiagnostic Medicine guidelines, the interpretation of the nerve conduction study without a needle EMG does not meet its standards and should be the exception in certain situations rather than the standard of practice. This is very important when you get reports that you order that they only did the nerve conduction study. Unfortunately for the academies and the physicians, there are a lot of there is a certification right now for technicians to do it, and some offices have been and some practices have been abusing this, and they're not doing the needle part. So it's an incomplete study, and the AA and MEM guidelines says that it doesn't meet its standards. So what is the nerve conduction? So it's when a nerve is electrically stimulated and the action potential can be recorded through the surface electrodes, and it's termed compound, and it's called the compound nerve action potential, CNA. I'm talking about these terms because through the lecture, I'm going to be mentioning this. So I want to make sure you guys have an understanding of this. And we have the sensory nerve action potential that is called the SNAP. We have sensory nerves and motor nerves. So when we do the nerve conduction study, we evaluate both of them. So the sensory nerve is studied in an antidromic impulse or orthodromic impulse. Antidromic impulse, it goes against the nerve regular impulse, and orthodromic towards the regular nerve impulse. We have the motor nerve conduction studies that are the CMAP. We also have the late responses. The late responses, we have the H reflex, that is the Hoffman's reflex, is the result from the activation of the lowest threshold of the fibers of a mixed nerve. And the F wave is the result from a supramaximal antidromic stimulation of a motor nerve. So the EMG testing, theoretically, the electrophysiologic signal resulting from the voluntary firing is the summation of the firing of all muscle fibers within the motor unit, action potential. So when we insert the needle, so when we do a needle EMG, we evaluate everything since we insert the needle and we move the needle into the muscle. So we check for insertional activity. We check for spontaneous activity, meaning the muscle is doing some noise and showing some waves that are not really activated by the person voluntary. So those are called fibrillation potentials and positive sharp waves, complex repetitive discharges, monotonic discharges that can come from a single muscle fibers, fasciculations, myotonic discharge, myochemic discharges, and cramps and neuromyotomic discharges emerge from the motor unit. So when you read the report at the beginning that you said after the conclusion, it will say an insertional activity in the following muscles. For instance, the abductor pollicis brevis was abnormal. This is where we describe all the abnormalities. So in the myelinating lesions, the CMAP and the SNAP demonstrate a potential conduction block and temporal dispersion when it's stimulated proximal. In this lecture, we are not going to talk about neuromuscular diseases or myotonias because it's like a huge topic and it's more complicated. So we're focusing only on the spine. In pure demyelinating lesions, there should not be firing of axonal loss on the stimulation. So in axonal loss, the compound mount, the CMAPs, I'm going to mention it, CMAPs and SNAPs. So CMAP is the compound muscle action potential, and the SNAP is the sensory nerve action potential. Amplitudes are reduced with the stimulation of the nerve proximal and distal to the lesion, as compared with the contralateral side with relatively preserved latencies and conduction velocities. So what is the latency? The latency is when we stimulate the nerve, it gives us a response. Remember, the nerves are myelinated and we're checking 1A fibers with needle EMG. We don't check small fibers, we cannot. So if you're suspecting a small fiber disease, you have to order a nerve biopsy. We check the, we have to check the conduction velocities in order to determine if there is axonal loss. So the amplitude will tell us, the amplitude of the wave will tell us, will evaluate the axons, and the latency will evaluate the myelin of the nerve. So on needle EMG, when we put the needle in, the supplied muscles by the affected nerve can show decreased recruitment, followed by the appearance of the nervation potential. So when we insert the needle, we tell the patient to contract the muscle, there's certain noise and waves that we see, and when there is the nerve is affected, there is decreased recruitment, and it's something that you learn with practice. So in the chronic stages, reinnervation follows with enlargement of the motor unit size, increased number of phrases, and duration. This is what this confirms what I mentioned before, that you can give prognosis on the disease with the needle EMG. So it helps us in localizing the injury. So electrodiagnostics is useful in localization of the site of the nerve lesion, whether it involves the root, the plexus, or the peripheral nerve. This is very important when we are checking for radiculopathies. We're checking for plexopathies or a lesion of the nerve, or a compression neuropathy, such in carpal tunnel syndrome at the carpal tunnel. So you can actually localize the nerve lesion. When you have injuries of the nerve, usually traumatic with a cut, or injuries with trauma, you can actually, knowing the innervation of and the anatomy of the nerve, you can individually check the muscles and localize exactly what the nerve injury is. So the presence of a normal sensory nerve action potential in the area of sensory loss is indicative of a lesion proximal to the root ganglion. This is very important, or it's in a central sensory pathway, because remember, you have the root comes out of the spinal cord, and then you have the dorsal root ganglion. So if the sensory response is normal, but you see that the patient has decreased movement or decreased strength in the muscles or in the limb, you can actually just know by a physical examination that the lesion can be proximal or distal to the root ganglion. Focal conduction, slowing or block on nerve conduction studies can localize a set of the entrapment. So for instance, in carpal tunnel syndrome, we stimulate above the carpal tunnel, and then you pick up the abductor pollicis brevis. That is one of the muscles that is innervated by the median nerve. So if you see slowing across the wrist, or you see a conduction block, meaning that there is no response of the nerve to a stimulation, you can localize where the injury is. The distribution of the abnormalities, as I mentioned before, in the muscle tested can also clarify the site of the lesions. So as I mentioned as well before, EMGs can be helpful in identifying neuromuscular junction disorders, myopathic and neuropathic disorders, through the motor unit action potential size, configuration, and stability. So the assessment. So identify whether a neuropathy is primarily sensory or motor, length dependent, and primary axonal of the myelinating process can also guide the classification and workup. So when we talk about neuropathies, we have neuropathies that are demyelinating and axonal, meaning we're checking for the myelin, the amplitude, and we have motor and sensory. So for instance, the diabetic neuropathies are mixed, sensory and motor, meaning they are axonal and demyelinating, and they are sensory and motor. Alcoholic neuropathy is another example of an axonal, sensory and motor predominantly. The EMGs can predict the activity of some myopathic disorders, the presence of fibrillations and positive sharp waves in association with short duration motor unit action potential indicates active disease, inflammatory myopathy. They disappear with treatment. So for instance, we use a lot of cortisone for the myopathic processes. So you can bring the patient, evaluate them, and then give a short course of cortisone and bring them back, and then reevaluate them to see if you see any myopathic processes. So in ongoing denervation, fibrillation, positive sharp waves, and decreased recruitment and polyphasic motor units are present. In chronic denervation, fibrillations and positive sharp waves are minimal and small in amplitude with large size polyphasic motor unit action potential. So this is an important point for radiculopathies. So for instance, if they send me a patient that they wanna localize which nerve root is more involved, usually L5 or S1 in lower extremities, for example, if the motor units are large and big, is usually more acute, and they're small and in amplitude, usually they're chronic. So we can call acute over chronic radiculopathy when there is a mix and match, or a purely acute or a purely chronic radiculopathy. So it guides the interventional physiatrists or the interventional pain management physicians in which nerve root to do. Also to the spine surgeons, and I will show an article in the next slides, it can predict if the patients are gonna improve, if they have a lot of spinal stenosis and they're gonna have decompressive surgery, if they're gonna improve or not. So the nerve measurements and prediction of outcomes. So the nerve conduction studies can be an indicator of the severity of a lesion. The larger the amplitude of the nerve action potential distal to the lesion, the better prognosis for recovery. The EMG can be a measure of the severity of the lesion. Abnormal spontaneous activity indicates axonal loss. The absence of a motor unit action potential in the muscle supplied by a nerve indicates no action potential traversing the lesion due to either axonal loss or conduction block. This is an example, for instance, in entrapment neuropathy such as carpal tunnel syndrome or cubital tunnel syndrome. By the way, during the pandemic, the carpal tunnel syndrome is the most common entrapment neuropathy, but during the pandemic, because of poor ergonomics, I saw a high increase in cubital tunnel syndrome because people were like working at home from, well, in the bed with the laptops or on the bar stools, on the bar, at the kitchen, on the stools. So we are gonna publish an article in regards of that. In electrodiagnostic studies, axonomesis and neuromesis cannot usually be distinguished. As the primary difference between the two is the supporting structure integrity, such as the myelin. Patients, as I mentioned before, with the small fiber neuropathies may show normal electrodiagnostic studies because we only check with EMG the large 1A fibers. So muscle biopsy is indicated if you suspect a small fiber neuropathy. And the nerve that they use for biopsies is usually the sural nerve. The same for nerve transplantation, they use it as well. So many findings in electrodiagnostics testing are sensitive indicators of abnormality, but are not specific for a disease. For example, in some myopathies, we can see fibrillations and positive sharp waves, as well as in radiculopathy. So it's very important, as I mentioned at the beginning, to make a whole consultation. People, when they send an EMG and nerve conduction study, they think that the physician or the technician plus the physician, because the physician has to do always the needle part, just go and do the test. But you know, we have to know what the physician that is ordering is looking for, and we need to speak with the patient and examine the patient thoroughly to see what we are expecting in the EMG. So we're going to talk about radiculopathies right now, cervical, thoracic, and lumbar. So a better topic. Physiology is always very confusing, or especially with nerve conduction studies that we do a lot of electric physiology. So approximately 60 to 90% of all radiculopathies affect the lumbosacral nerve roots, with the vast majority of these affecting the L5 and S1 nerve roots. Cervical radiculopathies only are 5 to 10% of all the spinal nerve root disorders, affecting C7, C6, C8, and C5 in decreasing frequency. Thoracic radiculopathies occur, but are super rare. Only 1.15 to 4% of the symptomatic herniation of the spine are thoracic radiculopathies. As the pathology is at the root level, the sensory nerve conduction studies, as I mentioned before in the physiology, are expected to be normal, given the proximal location of the dorsal root ganglion within the neural foramen. However, abnormal superficial peroneal and sural nerve action potentials have been reported with L5 and S1 root lesions, which may occur with a far lateral disc herniation that impinges the dorsal root ganglion within the foramen. This gives us, again, a lot of emphasis in the physical examination, the history taken, and any radiological reports or exams that the patient has had. So it's very important to check out the MRI, because sometimes when you have far lateral disc herniation, you can have, it can touch the dorsal root ganglion, especially in the lumbar radiculopathies. So the normal sensory nerve action potentials argue for more for radiculopathy versus a more peripheral lesion in patients with radiating extremity pain and or paresthesias, such as in L5 or C8, rather than a peroneal or ulnar neuropathy, respectively. Because if the sensory is normal, as we said before, is usually the root. If it's abnormal, it's usually peripheral. The CMAPs may be reduced by severe axonal lesions affecting the primary root innervation of the muscles used for pickup. Extensively term brevis for L5 radiculopathies during routine nerve conduction studies. And the abductor pollicis brevis and abductor digiti minimi for C6 and C7 radiculopathies. Also, we can have in patients that are diabetic that usually develop diabetic neuropathy that is a mixed, meaning motor and sensory, mixed, meaning axonal and demyelinating neuropathy, and they can have an overlapping radiculopathy. So we are gonna find out that they have decreased CMAPs and SNAPs, and then on needle EMG, they have fibrillations and positive shock waves. So they have both, and it's very common to see it, and it's very important to call it, because a lot of the pain, the neuropathic pain that the patients feel in this case is usually from the diabetic neuropathy and not the radiculopathy, because it's in a stocking or glove way. So as we mentioned before, the F waves, it's a specific wave that we use, and it's limited in the evaluation, but the waves are often normal in severe in less severe lesions, but maybe abnormal in polyradiculopathies, meaning more than one nerve root, plexopathies or peripheral nerve lesions. The H reflex also for S1 radiculopathy or for C7 radiculopathy. We can evaluate it. So sometimes when you see the report, you will see H reflex prolonged or F wave prolonged. So you know that it's either for a neuropathy or a radiculopathy. So the needle EMG remains the most widely accepted method for confirming the presence of a radiculopathy affecting the motor axons. Ideally, 6 muscles, including the paraspinals, should be screened for both cervical and lumbar radiculopathies, as sensitivities of needle EMG are relatively poor. In patients with cervical radiculopathy, sensitivities range from 50 to 72%, while sensitivities for lumbocervical radiculopathy range from 49 to 86%. Ideally, the electrodiagnostic examination should coincide with the development of the denervation potentials, such as positive shock waves, fibrillations in the axial and limb muscles. Usually, a spontaneous electrical activity first appears in the paraspinal muscles approximately 7 to 10 days following the injury, followed by the proximal and distal limb muscles several weeks later. So it's very important when you're suspecting something acute and you want to order an EMG to wait at least 4 to 6 weeks to order it, because at the beginning, it can be completely normal. And then we can see the chronicity or acuity of the radiculopathy based or deletion of the nerve based on the reinnervations. It follows the same proximal to distal pattern. The needle EMG should be performed, as I said before, approximately 3 to 4 weeks post-injury. The needle EMG abnormality is found in 2 or more muscles innervated by the same nerve root but different peripheral nerves confirm the presence of a radiculopathy. For instance, in L5 radiculopathy, we do the tibialis anterior, that is by the deep peroneal nerve, L5, and we do the gluteus maximus, the superior gluteal nerve, L5. If both are positive, plus the lumbar paraspinals, meaning the patient has an L5 radiculopathy. Also, for instance, sometimes when you have a patient with a foot drop and you want to make sure that it's not coming from compression of the deep peroneal nerve of the fibular head versus an L5 radiculopathy, first of all, you examine the patient. If you see that the patient has a Trendelenburg gait because the gluteus is not working, it's an L5 just radiculopathy by physical examination. If it's just a foot drop and they have eversion and inversion, and depending on the history of the patient, if they had trauma or that foot drop or the deep peroneal nerve injury is called the strawberry pickers palsy, because the strawberry pickers, they kind of like stretch the deep peroneal nerve because they have to squat up when they pick the strawberries. And then with the evaluation of the short head of the biceps femoris, that is the only muscle innervated in the thigh by the superior peroneal nerve, we can differentiate between an L5 radiculopathy and a deep peroneal nerve entrapment of injury at the fibular head. So paraspinal fibrillations and positive sharp waves may be the only electrodiagnostic abnormality found in about 20% of patients with lumbosacral root injuries and in 40% with cervical root injuries. We have to be careful when we get patients that have had surgery in the lower spine. That is very common EMG that they send patients that have developed what is called a post-laminectomy syndrome or intractable back pain, because the paraspinals are always going to be positive, so it's not reliable. So this is EMG before and after cervical anterior discectomy. I'm going to talk about a little bit about upper extremity here. So the median nerve that gives the sensation to the first, second, third, and half of the fourth digit in the palmar aspect is can be confused with a C6 radiculopathy that gives the sensation or is the dermatomal sensation to the first and second digits. So that's what is called the double crush injury. So for patients that have neck pain with some MRI findings that have also nocturnal symptoms for carpal tunnel, the surgeons are very important to send an EMG, and they do it most of the time to rule out a double crush injury. So in patients that had in this study that they did, that was published on Muscle and Nerve in 1995, it's an older study, but it's very relevant because it's not something that it will change. They studied 68 patients that they did EMG before and after the anterior cervical discectomy and fusion, and they found that the patients that had a positive EMG have before the surgery improved much more than the patients that had a negative EMG before the surgery. So this one is the predicting response to epidural steroid injections for lumbar spinal stenosis and an EMG. So this is the same principle. So we get the typical, above 65-year-old that has multiple level spondylosis with central spinal stenosis, neuroforaminal narrowing on multiple levels, and we're playing, or we're trying to find out which nerve root is bothering them the most, or which, because the interventionalist wants to do an epidural. So it's very important. I mean, we are not going to give epidurals to all the levels at the same time. So the interventionalists, they did this study where they send the patients and the EMG findings when they show, like, for instance, a patient that had multiple level spondylosis, and they showed that the most irritated nerve root was L5. When they did L5 first, they had a better prognosis in improving in pain than the patients that went blindly and had and they were treated by MRI, because sometimes the MRI shows a level that is more stenotic, but in reality they have pain from another nerve root. So it's another study that they did. So this is the study, mentioning the study, and they did. It was a very thorough study published at the Physical Medicine and Rehabilitation archives. They measure like very specific pain scores, and they check interleukin 1B, so they did a pretty good study. So mentioning in regards of for the hand surgeons, in regards of the importance, it will quantify carpal tunnel syndrome and cubital tunnel syndrome in reality clinical diagnosis. We don't need an EMG to diagnose it, but it quantifies it. It shows, it gives the hand surgeon a very good tool to see if it's mild, moderate, or severe, depending on how delayed the response is, and it will guide them in order to make the decision if they're gonna brace, inject, or decompress. So that's a very big source of referral. So the relevance to clinical practice and conclusion, electrodiagnostic testing is an extension of the physician's history taken and physical examination. Perhaps the best rationale to support its use is establishing whether nerve root injury is present and which roots are affected. The electrodiagnostic testing is also useful in situations of suspected acute or chronic disease, such as differentiating an acute radiculopathy from an underlying chronic radicular process, as may be seen in spinal stenosis. I mentioned that before. It is also helpful in distinguishing acute radiculopathies from other underlying neurological conditions, such as diabetic peripheral neuropathy, which can often obscure acute radicular clinical findings as we measure. The electrodiagnostic testing can help clarify a patient's diagnosis when imaging studies are equivocal. The MRI scans of the lumbar spine are known to have a high false positive rate, with one study reporting 27% of normal subjects having a disc protrusion. The false positive rate of cervical MRI scans is lower, with only 10% of asymptomatic subjects reported having a herniated or bulging discs. As surgical rates vary, electrodiagnostic testing can provide objective data to help identify patients who may benefit from surgical decompression. From time to time, I get a patient that had severe spinal stenosis in the cervical spine with a lot of numbness and tingling in the hands. They have the anterior cervical discectomy effusion, and they wake up with the same symptoms. They did not do an EMG. They come to us, we do the EMGs, and we find that the patient had a severe carpal tunnel syndrome. They go and get the cervical decompression for carpal tunnel, and their symptoms improve. It's super rare to have this, but I have seen it in clinical practice. So the needle EMG, for example, was reported to correlate well with nerve root injury at surgery in 70.86% of patients, based on findings of fibrillations and positive sharp waves in limb muscles in one early study. A later study compared the outcome of patients with lumbar radiculopathy from these herniations treated surgically to those with lumbar radiculopathy treated conservatively, but found the initial EMG had no prognostic ability to predict the outcome at 5 years. So at 5 years, there was no difference. For those patients considering epidural injections as a treatment for painful lumbar radiculopathy or painful cervical radiculopathy, a recent study found that those with EMG positive radiculopathy had a better pain scores and functional improvement after the epidural spinal injection than those with EMG negative radiculopathy. In a small study of patients with cervical radiculopathy, those with positive preoperative EMGs fared better after discectomy and fusion than patients with normal EMGs. This is another study that they did. Complications arising, people says, log, the patient has a pacemaker. Pacemakers are not contraindicated for a patient to have an EMG. Only if they have an external pacemaker is contraindicated. So complications arising from electrodiagnostics are rare. Imaging studies on patients after undergoing needle EMG demonstrated an aggregated risk of bleeding of 1% for all muscles, with no significant higher incidence seen in patients on systemic anticoagulation. So the needle is very thin. It's a acupuncture type needle, and it doesn't increase the maybe more small hematomas, but there is no significant difference. And they did a study with patients on warfarin. As I mentioned before, it's completely safe in patients with a cardiac pacemakers or defibrillations, but should be avoided in patients with external cardiac pacemakers. Usually we don't do it unless it's an inpatient EMG that the patient tries, they're trying to extubate the patient is stable, but they cannot see the diaphragm to work and they have an external defibrillator. It's the only time that you will say, no, I cannot do an EMG. These are the references. Any questions you have?
Thank you very much, Dr. Restrepo. Hopefully we will get some questions. I want to remind the audience that you may type your questions in the Q&A feature in the bottom of your screen, right in the middle. Please enter your questions, and that way we can engage Dr. Restrepo in some of the areas that he touched upon this afternoon, which, by the way, that was a very comprehensive recap of what an EMG is and in all the studies that you have addressed. It is mind-boggling how science has evolved in the past years, and especially in neuroscience, and the use of the EMG has been crucial nowadays for many of the conditions, some of which you listed today. I was actually thinking that perhaps we owe it to our peers to talk a little bit about two of the conditions that perhaps we see a lot in clinic, and it has to do with the diabetic neuropathies or the peripheral neuropathies secondary to diabetes, and also the alcohol neuropathies. In these axonal type conditions, we see patients that are extremely challenged in caring for themselves and making certain that they don't go into a more of a severe chronic type condition simply because they cannot feel the as you described them, the sock or glove type sensations that they feel in their extremities. Now, how often do you see in your practice patients with diabetes that have been diagnosed with diabetic neuropathy that will require some kind of an intervention?
In regards to intervention, like a medical intervention, giving medication. So it actually, there is a big study that they did in regards of like the severity of peripheral neuropathy diagnosed by EMG with the hemoglobin A1C. So the higher the hemoglobin A1C, the worse the neuropathy is. And actually they did like a 5-year study in a multi-center. It was in Seattle, University of Washington. It was Kessler, New Jersey, Norfolk, Virginia, Baylor, and University of Miami. They did a study that they followed the patients with higher, that were diagnosed with diabetic neuropathy by EMG. They look at their hemoglobin A1C. They told the patients, listen, your hemoglobin A1C is 12. It has been correlated that the higher the hemoglobin A1C, the less you take care of your diabetes, the more neuropathy you're gonna get, and the less probability of the neuropathy getting improved. And they followed those patients like for 5 years, and they saw that the patients that follow instructions, they lost weight, they start dieting, their hemoglobin A1Cs were more controlled, their symptoms got better, and their EMGs, the nerve conduction studies, actually got better. So neuropathy can be delayed. It's innate from the diabetes to produce neuropathy, but it can be delayed a little bit. And you can see it all the time. And it's a good tool to diagnose and to document, in the chart in diabetics that the patients have diagnosed by a tool, peripheral neuropathy. In alcoholics is also, and alcoholics is not reversible. I see it very often. And alcoholism is something that is not socially well seen. And, I start, you see like this kind of like healthy patient in their early 50s that come with these neuropathic symptoms that are sent usually by primary care physicians. And I start digging and making confidences and I start seeing like the pattern of like an alcoholic neuropathy. And I says like, do you drink alcohol? And usually their eyes like, poop. And I said, or are you a heavy alcohol drinker? And they're like, why? It's like, well, because you have an alcoholic neuropathy. And usually, 95% of the patients said, yes, they are they were alcoholics or they are like actively drinking alcohol. So it's another tool that will, open their eyes and say, listen, you're damaging your nerves. Either you have to take care of this or not.
You have to acknowledge the issue.
Yes.
This is the
So,
biggest challenge with alcoholics. Yes.
yes.
That is awfully interesting. And then one of the other topics that we also have talked about, it's the fact that the great majority of our population, our global population, suffers from some kind of a radiculopathy, or at any stage during their life, they're going to have some kind of a back pain. So you did mention that 60% of the lumbosacral radiculopathies are perhaps identifiable through this type of mechanisms. Now, it is extremely, extremely interesting that in some of our peers or some of our countries in different areas of the world do not necessarily go through an EMG to determine the type of radiculopathy or where exactly the root cause of the radiculopathy is. In our practice, do you feel that this is essential, that the neurosurgeon has to rely on the study?
No, they don't have to rely, but it gives them a good guidance, especially in patients that have multiple level spondylosis that are, it's like a Russian roulette. You don't know if they're gonna get better from the spinal decompression because they are symptomatic, but they are not impending paralysis or a cauda equina or a conus medullare syndrome. So they have failed epidurals. So they start thinking, let's see, they order the EMG. And then they start thinking like, they have studies, as I mentioned, that it shows that patients with a positive EMG have a better outcome if they have a spinal decompression and fusion. Right. So it's not something that they do routinely. Here at Baptist, we do it routinely because we have the tools, and it's something that we work as a team, and the physiatrist is the EMG, and especially for cervicals because of the double crush injury that I mentioned. When you could have concomitant carpal tunnel syndrome plus a C6 radiculopathy, and if they have radicular symptoms, it's very disabling for the patient. So to do an EMG is a must in those cases. In the lumbar, not as much, but in the cervicals, yes. We have a question actually.
Yes, we do. How often can I recommend an EMG in a diabetic patient?
So usually, if you, as a primary care physician, if you're monitoring the patient's A1C and you see that the patient has a well-controlled hemoglobin A1C and they're symptomatic, you order a first EMG. And then you get you get like a baseline and or how bad the neuropathy is, and then you monitor the patient. If you see that the patient you say, listen, you have diabetic neuropathy already, you have to control your sugars, etc., etc. And if you see that the patient is well controlled and the neuropathic symptoms have not increased, there is no necessity to repeat an EMG. But if you see that the patient has increasing symptoms or they are not compliant, etc., etc., it's good to repeat an EMG usually after a year.
We have another question from Ujoas. It says, hi, can you say anything about NCS results being normal with the CTS symptoms? What causes that?
So when we have a normal wave, so this is called the latency. And the amplitude of the EMG, of the wave. So when I stimulate the nerve, I get a response here. So we have a normal value. In the normal values that I use is less than 4, in the motor nerve is less than 4.4 meters per second. So if there is a delay, for instance, a 4.7, there is a 4.7 meters per second delay. So we have it mild, moderate, and severe. So if it's mild carpal tunnel syndrome, the sensory nerve that is stimulated will show us a delay. If it's moderate, the motor nerve plus the sensory, but the sensory still has a response. And in the severe, you will see a delay in the motor, and there was no response. There will not be a response in the sensory. That's how you quantify the carpal tunnel for the hand specialists.
Hmm.
I don't know if I made myself clear. So in the severe, there is very delayed response in the motor and no response in the sensory. In the moderate, there is delay response in the motor and there is a very delayed response in the sensory, but there's still a response in the sensory stimulation. And in the mild, the motor is normal, but there is a slight delay in the sensory.
So with carpal tunnel, is it recommended that we do the study on 100% of the patients, or by
Yes,
clinical,
100% of the patients.
they
Yes.
need to have that corroborated?
Because it will, if you have mild carpal tunnel, you start with bracing on local anti-inflammatory medications such as Pennsaid or Voltaren gel. If you have moderate, you start thinking about a carpal tunnel injection with cortisone and bracing as well. It has to be done both. But if you have advanced carpal tunnel syndrome, you start thinking about decompressing the nerve, the tunnel. Because what happens when the nerve gets compressed for so long, it gets axonal damage and it gets axonotmesis and neurodemesis. So there is a point of no return when there is nerve damage, and there will be the nervation of the thinner eminence muscles and the intrinsic muscles of the hand, and you will see atrophy. You start seeing the claw hand. You start seeing that the patients start losing strength and grip, and there is a point of no return. So they have to decompress the nerve.
That is fascinating. And then obviously we do have those secondary neuropathies that come from chemotherapy.
Oh, yes, definitely.
That, I'm sure they come to you as well.
Yes.
Can you elaborate a little bit about where we are in cancer care and post or the sequelas of chemotherapy?
Unfortunately, all the, mainly the platinums, all the cisplatinums produce mixed sensory motor peripheral neuropathy, but any chemotherapeutic agent can produce a neuropathy. And unfortunately, the more prolonged the chemotherapy is and the more aggressive it is, there is usually a damage of the nerves and produces neuropathy that is very disabling for the patients with weakness and sensory changes. Not only the sensory changes of the neuropathy, but they also have motor changes because the neuropathy is so severe that the motor nerves are affected and they become weak in the hands or on their legs, and it's becoming an amyotrophy. And talking about amyotrophy in diabetics that are very chronic and very severe, non-controlled, that develop neuropathy, the next step is they develop diabetic amyotrophy. Their muscles start to get affected because the motor nerves get affected, not only the sensories, and they get damaged, and they don't send a signal to the muscles, so the muscles get atrophied. They're replaced by fibrous tissue. So it's when you see those diabetic patients are very thin with very thin muscles that are weak, wheelchair bound, et cetera, et cetera. The same happens with the cancer patients. Unfortunately, it's either chemo or, you have to go through
or deal with the consequences later. Yes. We're almost close to the top of the hour. We're going to give you some time back, but something that stuck in my brain was the fact that you said that EMG positives in lumbar radiculopathy fare much better than those that are negative. And I wonder if this is a common practice throughout the world to actually have the patient undergo the test or doing an EMG in order for them to determine if positive or negative, in order for them not to just go through surgery.
I agree. It's something that it should be done. You know what I mean? I think, and it depends on the surgeons and where they come from, but here at Baptist, there's so open-minded, and we work such a big team that mostly every patient that is going to have a spine surgery is going to have an EMG prior to a spine surgery. We have a lot of data that the patients. I'm a little nerd, so I always go and look back when the patients have surgery, are going to have surgery. I follow them on my own. Like I kind of go and see, do you improve? Or I talk with the surgeons, with the follow-ups. I go and look at the charts, and we have data that we can polish. I was thinking about publishing, as I told you, with the pandemia, people working from home with poor ergonomics, people working with their elbows like this in the
Elbows, yeah.
bed, with their laptop computers. They were developing a lot of cubital tunnel syndrome. And I saw a lot of cubital tunnel syndrome increase in the year 2020, 2020 and 2021.
Yeah.
And I was speaking with Dr. Ouellette, our hand surgeon, and just said
Yes.
we should publish this because in the past couple of years it has been more than the plain carpal tunnel syndrome.
Wow, that is phenomenal. You know what, Dr. Restrepo, this is a fascinating topic, and I know that we're going to be able to have you back in the future so you can talk to us about other type of technologies that we're using at the Miami Neuroscience Institute. So we're going to give you all a little bit of time back. It's 4:50. So I want to make sure that I thank all of you on behalf of Baptist Health International, especially you, Dr. Restrepo, for accepting our invitation and for your informative presentation. And of course, to all of you for always attending and participating in our lectures. If you have additional questions for Dr. Restrepo, please feel free to email them at BHIWebinar@baptisthealth.net. Let me repeat that. It's BHIWebinars@baptisthealth.net. We look forward to seeing you all in our next neuroscience lecture series, which is tentatively scheduled for July 20th, 2022. Thank you again. Have a great afternoon. Thank you, Dr. Restrepo.
Thank you very much for having me.
Of course.
It's a pleasure always to be here.
Thank you so much, Jack.
Okay, bye.
Thank you.